Assalamualaikum and good morning, everyone. Welcome to Breakfast at UMHealth episode 40. I'm Rafi, and I'll be your moderator this morning. Today, we are delighted to have Prof. Dr. Muhammad Idzwan Zakaria, Professor of Emergency Medicine with years of experience, and also a strong advocate for integrating geriatric care into emergency practice. Today, we'll be sharing his insight on GEMness and approach to improve all the person management in ED. As an aging nation, I believe this topic is both timely and important. During this session, if you have any question, please post them in the Zoom chat. We will try to address it at the end of the session. Without further ado, I would like to invite Prof to share his experience and perspective on this important topic. Welcome, Prof.
Thank you so much, Dr. Rafi. Thank you to the organizing committee, Visibility, and the rest of the administrators in order to allow me to speak today. As we are short in time with regards to timing, so I will start my PowerPoint to be shared now. Right. My topic today is GEMness, a novel approach to improve older person management in the emergency department. You probably think, what is GEM? It is Geriatric Emergency Medicine Nurse. As an introduction, Malaysia is now feeling the waves of the silver tsunami as its population is aging rapidly. Is our emergency medicine department ready for the demands of an aging nation and moving towards an aged nation in 2030? This is the usual scenario in our emergency department, not only in University Malaya Medical Center, but also throughout the country. Yeah, it will be chock-a-block with patients, overcrowding, and also as due to surge as well as access block. And mind you, in our hospital here in UMMC, we have about 60 to 70% of patients waiting in the emergency department are actually older people. Our emergency department is time pressured. And because of the surge of patients, this overcrowding, our doctors tend to concentrate on single system centered management. And not only our doctors, but our nurses and also our paramedics are actually geared towards life-threatening and limb-threatening conditions. We tend to forget that older person is somewhat different, and the direction is actually towards a person-centered care. The concept of geriatric 5Ms is not well mentioned in most undergraduate medical curriculum. And mind you, postgraduate emergency medicine has already embraced this concept, and hopefully it will be one of the pioneer outside the geriatric medicine fraternity to embrace such concept. We have to know that older people are actually has issues of mind, mobility, medication, multi-complexity, and of course, what matters most. I've already written a few articles in the newspaper, and one of them is the issue of our emergency department's care for these older people. Where do they go after discharge? If one is discharged, is it adequate only to give a discharge note to an outpatient facility? So that is the question that hopefully I can answer and also enlighten you in this presentation. Based on that article, I would actually mention to everybody the importance of transitional care of these older people once they have been discharged from the emergency department. Mind you, it will be similar also from other wards, yeah, including especially geriatric ward. However, yeah, we have to embrace the concept of transitional care from the emergency department. So what is transitional care? It is a coordinated effort to ensure patients receive continuous and consistent care as they move between hospitals, clinics, and home. And this transitional care is geared towards older people. It involves more than just a discharge note. It includes a personalized care plan, family education, and coordination among doctors, nurses, and community health providers. One of the most important principles that I want to highlight in this presentation is that emergency medicine does not hover only at A, B, C, D, airway, breathing, circulation, disability, or airway, breathing, circulation, and defibrillation. And geriatric medicine does not commence in the geriatric ward or in the clinic. Yeah, geriatric medicines should be should be commenced and start from the primary care perspective. Yeah, and today is the emergency department. Let's have a look at a common scenario in our emergency department. This is a real life story. An 84-year-old woman with a history of major neurocognitive disorder secondary to intracerebral bleed the year before. Yeah, she came in from the nursing home. Yeah, brought by her daughter. Yeah, after an unwitnessed fall in the nursing home. She complained of pain over the right mandible, yeah, with swelling, yeah, and a history of dizziness prior to the fall. This is very important, yeah. She has pain, swelling, yeah, and a history of dizziness before the fall. Now, she denies any chest pain, shortness of breath, and also deny any urinary or upper respiratory tract infection symptoms. The GCS was full, 15-15. There was no stridor, no sweat, but there was swelling and bruise at the right mandibular region. The blood pressure was 129/85, the pulse rate of 90, blood sugar was 5.6. Yeah, and the medical officer continued with the looking at airway, breathing, circulation, disability, and exposure. Cervical spine was non-tender, no step deformity, lungs was clear, chest spring was negative, abdomen was soft, non-tender, moving all limbs, yeah, and the bloods were taken and imaging ordered. Yeah, IV tramadol was administered to this older person. However, the medical officer has forgotten the concept of adjusted shock index, in which, once calculate the heart rate multiplied by the age, age of 84, heart rate of 90, with a systolic blood pressure of 129, you get 59. Yeah, and if it is more than 50%, that means there is a feature of occult shock. But yeah, being an older person, yeah, the medical officer said, "Oh, this is normal, 129/85." Yeah. The medical officer also has forgotten to actually check for postural hypotension. The other thing that the medical officer gave was IV tramadol. We have a principle in emergency department is that for older people, you don't give tramadol. It's called tramadone. Tramadone. Because why? Yeah, it can cause further giddiness, of course. It can cause a delusion. Yeah, and hence it will actually increase the risk of fall in this older person. Our a good medical officer concentrating on the pain and swelling over the right mandible because the patient also has giddiness. Proceed with CT scan. Yeah. And from the CT scan and reconstruction, there is a fracture of the mandible, a stable fracture. The bloods were somewhat normal. The full blood count, the troponins, kidney function, and liver function. It's not too bad. CRP was not done. Just based on the normal total wide, normal troponin. Yeah. And because of the medical officer only looking at life-threatening, limb-threatening, so the medical officer scope only on a single organ management, referred to our colleague at the OMF, and copy and paste history, detailed examination of the face, because OMF is looking at the head and neck. Yeah. The maxillofacial per se, and a diagnosis of undisplaced fracture of the right body mandible was made, and a conservative management was planned and discharged with analgesia and to follow up in the OMF clinic. Unfortunately, yeah, once after discharge for 20 within less than 24 hours, she arrived back with recurrent vomiting, yeah, with headache. Seen by an emergency physician during rounds, identified the issue of readmission within 24 hours. Our MSQH, if there is a readmission within 24 hours, a senior person has to come and see. Examination of the abdomen was normal, no pain, no tenderness, no chest pain either. The emergency physician, who is very well versed in terms of older person, noted that this patient is actually frail with CFS, clinical frailty score of 6. If you guys have come to my presentation late last year, I've introduced you the concept of frailty as a vital sign. So CFS 6, the blood pressure, orthostatic hypotension was identified. Yeah, and however, the mentation was quite similar to baseline. The MY480 of 3, other examination was somewhat normal. However, the urine FME shows features of UTI, and IV fluids was administered and given antibiotics. The medical officer sent for CT brain. Again, there was no ICB. As you can see here, features of UTI was made, yeah, based on the urine FME. An impression of post-concussional syndrome, orthostatic hypotension secondary to dehydration from urinary tract infection. So the case was referred to medical team, and medical team discharged the patient with follow-up in outpatient. So the emergency physician was querying whether this patient needing admission or a better disposition in terms of the issue of transitional care in this older person. So the emergency physician withhold the discharge by medical, keep the patient in observation ward for a comprehensive geriatric assessment the next morning, with looking at a possible admission to virtual ward for better transitional care. This is the comprehensive geriatric assessment, and mind you, it was not actually done by the medical officer or the emergency physician, because as you know, we are swarmed with patient overcrowding. It was actually done by our geriatric emergency medicine nurse. All right. The CGA, which was made by the GEM nurse, was discussed with the geriatrician in charge of the virtual ward. The GEM nurse counseled the carer for prevention. An assessment was later made by the geriatrician. She came down and enrolled the patient in the virtual ward. The patient was discharged and monitored with proper instructions and counseling to the carers during the admission, especially on fall prevention. After 2 days being in virtual ward, she was discharged from the virtual ward and referred to rehab clinic, memory clinic, and pharmacy with further assessment in the OMF clinic. So that is an example of how GEM nurse work. And this is my GEM nurse. Currently, they are trainees, and hopefully they will complete their training in emergency department and also in geriatric ward together with geriatric clinic and also other institution outside UMMC, and hopefully they'll be graduating in December 2025. So what is GEM nurse? GEM nurse is a specialized or clinical nurse educator with expertise in geriatric care integrated into the emergency department team to address the current challenges. They attend to the complex medical needs of older person attendees, identify atypical presentation. They are experts in geriatric giants and syndromes, prevent adverse events and complications, and assist, as you can see, in terms of care coordination with existing services such as virtual ward, fall and syncope clinic, geriatric clinic, etc. The evidence of the use of geriatric emergency medicine nurse in the emergency department is well documented, especially in the US, in Canada, and also in our beloved neighbor Singapore. How do I actually create the GEM nurse? Most important is actually the curriculum, and I consulted multiple advisors from international as well as our geriatric medicine colleagues here. I got the curriculum mainly from Ireland and also in Singapore from Dr. Rosa McNamara, who is the chair of the GEM SIG in International Federation of Emergency Medicine. She's also the clinical lead for National Clinical Program for Emergency Medicine in Ireland. And also Dr. Juliana Poh, who is the senior emergency physician in Woodlands Health in Singapore. And in UMMC, I have Prof. Terence, Prof. Tan, and also Dr. Deepa to assist me as curriculum advisors, as well as lecturers and clinical facilitators. The important tool for GEM nurse is the comprehensive geriatric assessment, which is a multi-dimensional, multidisciplinary process to optimize care for frail older adults. And this tool actually assess medical conditions and medications, functional status, especially mobility and ADL, cognition and mood, and social supports and environment. This tool actually assists the GEM nurse in coordinating multidisciplinary input, advocates goals-based care, and patient-centered care. The outcome is to improve survival, reduce admission, reduce functional decline, institutionalization, and reduce adverse events. In Singapore, they have had a geriatric assessment team as part of the emergency department unit. A study was conducted way back in 2018 of a intervention team for older person presented with falls, and this was done in Singapore General Hospital. This intervention team consists of GEM nurse to do the CGA, and also consists of physiotherapists, occupational therapists, and also another nurse from the Agency for Integrated Care. Dr. Julina Po has brought this study and this principle and concept to Woodlands Health. And as you can see here, based on the slide and EMR, to show the use of the intervention team for assessment as well as intervention. And they have specifically mentioned in the EMR. And mind you, we still don't have proper slot per se in the EMR, and hopefully that is the direction that we should be leading to. This is the some of the current implementation and some future directions for to create a geriatric-friendly ED, and that is the direction that we are heading for. To identify geriatric ED interventions, cognitive screening at triage. We have just presented yesterday in my emergency department on the incorporation of delirium triage screening. And hopefully that will be implemented soon, of course, with adequate training, credentialing, and privileging. Clinical pharmacists looking at de-prescribing. I have also approached Dr. Sharon from the faculty and with the assistance from the primary care physicians to commence clinical pharmacists to look at polypharmacy among older people. Mobility support, improving care transition, improving staff training and culture change, and also hopefully looking at data-driven quality improvement. So in conclusion, the importance of improving, in this presentation, I actually enlighten you on the importance of improving older adult care in our emergency department, turning our emergency department into a geriatric-friendly ED. The role of GEM nurse in safety and continuity of care are highlighted, including the betterment of care transition, enlighten you on the role of CGA as a cornerstone tool for GEM nurses, and value of early identification of geriatric syndromes and multidisciplinary pathway intervention, and also, of course, GEM nurse to bridge emergency department and geriatric care. With that, thank you.
Thank you, Prof, for that enlightening and passionate presentation on the vital role of a GEM nurse. I believe we now have some time for question. Uh, Prof, Singapore seems to have done particularly well in integrating geriatric care into their emergency department. What do you think were the key factors behind their success?
One of the key factors in their success, of course, are having champions. That's the most important. Yeah. Champions who can actually work in terms of changing the mindset, and also looking at protocols, looking at training, and looking at systems. This mindset and culture with the pushing from the champions, it will be improved. And of course, Singapore, I always say to my Singaporean counterparts that we are actually 10 years behind them. We are 10 years behind them. Despite them having emergency medicine started somewhat later, about 2 years later than us in Malaysia. So yeah, I think having champions is one of the important, and of course, a good hospital administrators, yeah, to actually to look and assist the champions, and of course our friends and colleagues in geriatric medicine, who is always supporting us. Yeah, thank you.
Okay, Prof. So we need to find our champion lah in emergency department. Okay. For the follow-up question, Prof. From your experience in establishing the GEM nurse in our ED, what are the main barriers to establishing geriatric-friendly ED in Malaysia?
One of the issues are actually human resource. And we are so lucky that we have a very dedicated matron Norina. I have to mention here, matron Norina, who is actually fully dedicated to actually provide and also assist, especially in terms of providing staff, allocating sufficient time for them to train. And I would also like to thank Matron Hashimah for agreeing. And that is a big step for UMMC. And that's one of the key role of the nurses. Yeah.
Okay. I think that's all time that we have. Thank you, Prof. Idzwan, for the inspiring sharing, and thank you to all participants for joining us this morning. Today's session highlighted how GEMness serve as a crucial bridge between emergency and geriatric care, ensuring safer transition and better outcome for our older and patients. On behalf of the Faculty of Medicine, Muslim Malaya, I wish to thank everyone for being part of episode 40 of Breakfast at UMHealth. Thank you, Prof. Thank you, everyone.
Thank you.
Bye.
Assalam.